Okay, the thorax. So again, with as we continue to do this, there's going to be certain things, certain big tables, that have a lot of information in them. I'm going to point out the most important, and then I want you to go and walk through these as well on your own, kind of read through them and see if there's anything that you don't know right off the bat. That's the kind of stuff you want to focus on. So here, these first two chunks, thoracic inlet versus thoracic outlet. Most commonly, the thoracic inlet is going to be talked about on the exam. And that's because anatomists and pathologists, specifically anatomy and like physical anatomy in like a chiropractic world and anatomy in the physical therapy medical world, kind of butts heads a little bit in some regions. This is one of those spots. So the thoracic inlet refers to the superior thoracic aperture. So the top part of the thoracic cage, where the first rib wraps around at the top. However, when talking about pathology, a super common pathology that gets talked about is thoracic outlet syndrome. So thoracic outlet syndrome is referring to the neurovascular bundle that's leaving the neck region through the thoracic inlet. So it gets named a little bit weird, and it honestly just depends on who you talk to, what they're going to call it. The trick to remembering this is going to be, if you're talking about anatomy in general, so it's just purely anatomical, call it the thoracic inlet. If we're talking about pathology, so we're talking about the neurovascular bundle being squished, being compromised, having symptoms, that kind of stuff, call it the thoracic outlet. Okay? It gets a little bit confusing, but that's the best way that I can kind of clarify that. Then the thoracic outlet, the true thoracic outlet, is the inferior thoracic aperture, and that's going to be the bottom part of the thoracic cage. So see, we call this is technically the thoracic inlet, but if we're talking about pathology, we talk about thoracic outlet syndrome. This bottom portion here is the true anatomical thoracic outlet. Okay, we have a bunch of other structures here. We have the ribs, 12 pairs of ribs. The 1 through 7 are true ribs. They attach directly to the sternum. The ribs 8 through 10 are our false ribs. They attach through cartilage to the sternum. And then the floating ribs don't have any connection. Those are ribs 11 and 12. The sternum, we have 3 parts: the manubrium, the body, and the xiphoid process. They like to ask questions about that. If you're in an anatomy course, you'll also get questions about how many ribs connect to each part of this. The tricky one is rib number 2 meets or connects where the manubrium and the body meet as well. So the first rib attaches the manubrium. The second rib connects into the manubrium and the body. So if you're counting, if it asks how many ribs are on the manubrium, we say 4. How many ribs are directly connected to the body? That is going to be ribs 2 through 7. 2, 3, 4, 5, 6, 7. So 6. So there's 12 that connect directly to the body of the sternum. 4 on the manubrium, 12 on the body, because we count rib number 2 twice. Vertebrae, again, we'll talk a lot about the vertebrae and all of its individual components, more in the spinal anatomy chunk. Now, the esophagus goes right through the thoracic cavity, and we'll talk about its relation to the diaphragm in just one sec. The diaphragm, there's usually a good number of questions about the diaphragm itself because it has a lot going on with it, both from a pathological standpoint and from a physiological and anatomical standpoint. So the diaphragm is our muscle of respiration, and there are 3 openings in the diaphragm. We have an opening for the aorta, and this opening is located at T12. You can kind of see the diaphragm how it has back and kind of scoops forward, so it's lower in the back than it is in the front. So the aorta, there's an opening for the aorta at T12. There's an opening for the esophagus at T10, and then there's an opening for the inferior vena cava at T8. They like directional spots, so remember that T12, T10, T8, and where they are opening to. Then there's also the ligaments of the diaphragm. You have a couple of different ones. You have 2 cruce ligaments. Cruce because they look like that they cross. There's the picture of them. We have the right cruce and we have the left cruce right there attaching to the vertebra. And the left cruce ligament will actually, both of the cruce ligaments, they come together to form the median ligament with an N. Then we also have a medial arcuate ligament from the psoas fascia, and then a lateral arcuate ligament from the quadratus laborum fascia. Most of the time, they're going to ask you some type of question. When you have groups of 3, they like to ask questions because there are already 3, so they just have to give you one weird answer. So again, coming to some of the not questions, which of the following is not one of the ligaments of the diaphragm? And they'll throw in there a distractor, some distractor, but we need to remember median, medial, and lateral ligaments of the diaphragm. The other way that they could ask this, they could try and confuse you between median and medial, and they'll ask the question something like, the cruce ligaments of the diaphragm come together to form the blank ligament. And then median and medial will both be options on there. So we just need to remember the cruce ligaments are the median ligament. There's that inlet. There's those guys coming out through the diaphragm. Here's the domes, the cruce ligaments, the true ribs, false ribs, floating ribs. More of those ligaments coming and how they connect in. There we go. Later on, we'll talk about the lungs, the heart, and the mediastinum, which are all part of the thorax, but there's a dedicated section for that specific material. Okay, and the next chunk, we will dive into abdomen, pelvis, and the perineum, which will be split up into a couple of different videos.